I came of age in the 70s. Who knows what was in whatever that stuff was we were smoking? I just remember young people, there was a reason why we had double-sided albums. Staci, you know what I mean by
yes, extended
women
play.
of a certain age will know what I mean by that.
That's exactly correct.
Dr. Staci Gruber is a neuroscientist at McLean Hospital who leads the MIND program, studying how cannabis and cannabinoids impact brain health, cognition, and mental well-being. Now, as a personal aside, we met a few years ago at one of these sort of, think tanky kind of dinners. And I was lucky enough to be seated next to Staci. And I think we talked the entire time. Did I even say hello to anybody else? Because there was like an immediate connection and we just hit it off immediately. So I feel like this conversation is a long time coming and I am so delighted to have you. So welcome to the Second Opinion, Staci.
Thanks so much for having me. And you're exactly right. It was, we met, we launched into a conversation that really went the entire dinner, which I thought was great. You never know who you're going to sit next to at these things. And often it's people that you wish you weren't next to. It's always a good sign when you say something about what you do and somebody asks you a question because of a paper they just read and it's your paper. You're off to a good start, right? That was it.
There we go. I love this. And the timing on this is perfect because we have some news of the day. And for, 70 years or so, marijuana has been classified as sort of a Schedule 1 drug. And for those of you who don't understand what Schedule 1 drug is, that is, heroin, the most dangerous and addictive narcotics are in Schedule 1. And it recently has been recategorized to a Schedule 3. So, Staci, can you tell us what that means and why that is important?
Sure. I think many people forget that cannabis was actually part of our pharmacopoeia starting in 1850, which meant that doctors could and did prescribe it. There wasn't any kind of recommendation or certification for use. It was an actual prescription. It fell out of favor through a series of events, and in 1937 became illegal. In 42, it was placed in the most restrictive class of the Controlled Substance Act in 1970, Schedule 1. By definition, no accepted medical value, high liability for abuse, and no accepted safety profile, where it remains today, alongside things like heroin. Just for a fun fact, things like cocaine are Schedule 2. That always shocks people. So that's an important change. The proposal to shift from Schedule 1 to Schedule 3, first and foremost, in my mind, signals to the nation that there is accepted medical value for at least some indications and some people. For folks like me who are involved in research of Schedule 1 substances, I'm required to have a federal and state Schedule 1 license, and the requirements, for example, for storing Schedule 1 substances and dispensing, there are all sorts of hurdles and requirements that you have to meet for Schedule 1. That changes a bit when you shift to Schedule 3. And this proposal really signals to the nation, again, first and foremost, more common sense sort of approach. Maybe we should re-examine this particular classification because it wasn't necessarily science that drove that distinction. It was a series of socio-political moves, really, that landed it in Schedule 1.
And wasn't the history of this sort of demonization of marijuana really the work of one man?
I think you're talking about Henry Anslinger, who was the head of what would become the Office of National Drug Control Policy. And there were lots of really inflammatory and provocative things that were said and printed. And when you go back and look, you're sort of taken aback and you think, is this for real? And the answer is, yes, it was for real. And there was an awful lot of rhetoric about this, right? It was a very, very hot topic and people were very, very upset and concerned about it. The poster behind me, Assassins of Youth, this is a real poster. These things behind me are real, from the Reefer madness days. And this is important as a historical sort of milestone to remember where we've been, right? And Reefer madness, that entire mentality really set people on edge with regard to cannabis and cannabinoid exposure. And so, again, there's been two different schools of thought at this point, right? We have people who say, listen, there's no way we could ever consider something like cannabis medicine. Absolutely not. It's the devil's lettuce or the devil's weed. And on the other side, we have people who say, listen, This is natural. You should put it in the drinking water. There's absolutely no risk or harm associated. And like most things, the truth is likely somewhere in the middle. In one of the posters behind me, it really illustrates somebody injecting his female companion with, I guess, what it's supposed to be cannabis. I've never actually seen people do that. Only in preclinical experiments with rodents. But again, this was enough to get people extremely upset. So we've come a long way, and there are still many, many people who have that type of perspective. So I always say it's very important to let science and data lead the way.
You know what's funny? In preparation for this interview, I went back and looked up Reefer Madness and watched it, because this used to be a ritual in college. Like
Yes.
around exam time, everyone, you'd go and pull up and we'd have a screening of Reefer Madness.
Right.
And for the young people that don't know what it is, it's ridiculous. But it turns out that people, you would smoke weed and then you'd kill people. You became a homicidal maniac after smoking weed, which was a little bit of an exaggeration. But Anslinger, I guess is how you say his name, actually, he had an agenda. And the demonization really came about when, I should say, it's a classic example of sort of, what should I say, the criminalization of Black people in this country. And so at that time, I guess it was in the 30s, cannabis was associated with jazz, these, hip
Jazz
dudes,
musicians. Yeah.
jazz musicians, Black people, and Mexicans. So, that was my goodness, let's make sure we get rid of that scourge.
Right.
Yeah.
Right.
Just having marijuana be a Schedule 1 as opposed to a Schedule 3. It's hampered your ability to do the research that you do. And one of the surprising things that you said to me at dinner is like all of the hoops that you had to jump through to even get access to the marijuana or the cannabis to do your experiments.
So it can be a challenge to do clinical research with cannabis. Again, there were all sorts of policies in place regarding what types of products you can use. So many people don't necessarily know that we can't do clinical trials, for example, on products that are in the marketplace. I've had more people say to me, listen, why don't you just do clinical trials of this product versus that product, and then we'd know. And that makes a lot of great sense. If something's in the marketplace, we should know. Is it working? Does it do what we think it does? And, what might we be mindful of? But truth, in fact, you actually can't do a clinical trial of a product that's already in the marketplace. So if you want to do clinical work with cannabis or cannabinoids for a very long time, the National Institutes on Drug Abuse, or NIDA, was the single source for cannabis. So that's important because I will tell you, they have expanded the drug supply program exponentially in the last 15 years. Really unbelievable. But it still doesn't resemble anything close to the landscape that our patients and consumers have access to in the real world. It just doesn't. It certainly doesn't have any resemblance to the multitude of platforms or products available. More recently, the DEA has allowed licensed operators to provide cannabis and products to researchers, clinical researchers like me. So that's another step forward. Some of us are a little bit more creative in terms of how we do things. And so you can create products using either cannabis or hemp, depending on what you're looking for and how you're studying it.
So this would be a good point to explain to our listeners not just what these drugs are, but what's the difference? Like CBD, when you're talking about hemp-derived products, those are basically that are heavily CBD as opposed to THC. And some, give us a little framework about what that means and what's in
it. So the quick and dirty Cannabis Primer 101, right? Mm-hmm. So cannabis, basically, from plant Cannabis sativa L, the plant is comprised of over 500 compounds. Right? These are things like phytocannabinoids, phyto meaning plant, cannabinoids, things like delta-9 THC, primary intoxicating constituent, cannabidiol, a primary but not the only non-intoxicating constituent, often touted for medical purposes, cannabinol, cannabichromine, tetrahydrocannabivarin. I could go on. The so-called minor cannabinoids that actually may play a major role in lots of different conditions. Terpenes, the essential oils that give cannabis its characteristic scent and flavor profile, also have their own health effects, as it turns out. One very common misconception, though, is people often buy a product that they think is, quote, just CBD. Just like the plant is complex with over 500 compounds, this unbelievably miraculous plant, products can also be complex. And when people hold up a product and show me this, Dr. Gruber, I'm just using this CBD, I look and I go, oi, no, you aren't. You're using a product that's a full spectrum product, which may be terrific. Studies have demonstrated that whole and broad spectrum products may give you greater clinical efficacy at lower doses than a single extracted isolate form of a cannabinoid. But they often don't know that. As a result, they may test positive for drug, for let's say THC. When we test people for, quote, cannabis or marijuana, what we're really looking for is THC and metabolites of THC most often. So that's important for people to know. Some people who are super sensitive to THC, super sensitive, don't realize that some of these products, even within the legal limits of the law, may contain enough to actually push you over the edge of, oh, I feel a little better, to, oh, I feel terrible. For some people, that's true. So it's important to know, quote, what's in your weed, especially when it's something that you haven't tried before. So products can be complicated.
Yeah. And that's why it's important that you've got to do the research, because if you don't, how do you know? And how do you know of all these products that are out there that are available commercially, and you don't know what they are and what they do. I got interested in this a while ago because when I was still practicing, I practice in the District of Columbia, and of course we have legalized medical as well as recreational, and I actually registered to be a prescriber for cannabis because there were so many conditions that I used for my patients in gynecology. And I think the indications that I used it for was really things like chronic pain. You're trying to decrease the risk of them taking more narcotics. So you would use, cannabis for that. We use it for our cancer patients sometimes. It helped with nausea and it helped with appetite. But historically, that's not new. What are particularly in gynecology, what were the indications pre-1937? Because, you said it's been around for 1,000 years. This isn't new news.
Forever.
What was it being prescribed for when it was part of the pharmacopoeia?
So references to cannabis in various cultures go back thousands and thousands of years. Almost every culture has documented sort of references to cannabis somewhere. And, I have a great bottle from the Lloyd brothers from the early 1920s. And it has a very long list of indications, and it including depression and all sorts of urinary issues. And the last line says, feeling of general contentment, which I thought was fantastic because it's this very long list, almost any indication you can think of. And then the last is feeling of general contentment. We heard stories of Queen Victoria using cannabis to help with menstrual disruption and discomfort during menstruation. There are various indications that people would report relief from cannabis way back in the day, primarily pain. We were talking about things that were related to pain. We were talking about things related to specifically for women in gynecologic pain. There's a reference from, I want to say it was the late 1800s, that menopause actually was being treated effectively with cannabis. Today, when we think about the top 3 indications for people interested in using cannabis, what do we hear? Chronic pain, mood or anxiety related issues, and sleep disruption. I always maintain the following is true as we move through life, right? Through our lifespan, especially women. What are the top things that we are plagued by, especially as we enter menopause, right? What do we hear about? We hear about mood changes. We hear about sleep changes. We hear about joint and other pain. We hear about hot flashes or night sweats. We hear about vaginal dryness, discomfort during sex, low libido. We hear all sorts of things like this. And so it's no wonder that people turn to cannabis or cannabinoid-based products as a means of getting relief. And from most perspectives, there are real reasons that these people stay pretty invested in their treatments.
So, I think I was reading one of your papers and it was saying that about we have in our bodies an endocannabinoid system. Just simply means that we our ovaries actually make some version of a cannabinoid type product. It has some function, and we have receptors for it, correct?
We do. So the endocannabinoid system, every mammal has an endocannabinoid system, which is basically a series of chemicals and receptors throughout the brain and body. Right. And what's its job? Homeostasis. And that's a very, very important thing when we think about things like regulating body temperature, sleep, mood, anxiety, appetite, all of these things, homeostasis. When we think about women's health, we know that endocannabinoid receptors are prominent throughout the female reproductive tract, right? We know that estrogen changes the function of these receptors. So when we start having a change or a shift in estrogen and progesterone, as we do, is again, unfortunately, biology is cruel. Things change over time. We don't stay in the same state. But it stands to reason that maybe tweaking the endocannabinoid system with a bit of exogenous cannabinoid or something outside from the plant may actually help people feel better.
So that is fascinating to me, because a lot of, this is where our worlds collide, because I am always looking for things for perimenopause and menopausal women. And obviously, HRT is a big part of that. But you did a survey, and I think you recruited for this, and you were just asking women, I think you were looking for, what were the keys, cannabis and perimenopause and menopause.
Right.
And what were the results that you got from that survey?
So in our work, so as part of the Marijuana Investigations for Neuroscientific Discovery program, MIND, at McLean Hospital and Harvard Medical School, I started a program called WIM, the Women's Health Initiative at MIND, specifically dedicated to looking at indications or conditions that either exclusively or disproportionately affect women. Mm-hmm. And the reason for that is because women are so vastly understudied, and so many of these conditions are so vastly underreported. You talk to them, they say, oh, I just live with it. It's this, that, or the other. Yeah, my pain's at a 7 out of 10 most of the time. Wait a minute. What? Why? Why are we living with this? One of the ways that we started our work in terms of looking at people who were either perimenopausal or postmenopausal was through a survey-based study. And we found that individuals who were using or interested in using cannabis were using for symptoms associated, again, with peri and postmenopausal symptoms like sleep and anxiety. Those are the top two. That's really, really important. That finding, I think, has been replicated in another survey study much more recently. But that's really important, right? Again, it mirrors what we see in the bigger picture in this country. So when people say I'm using for sleep and anxiety, that's because they're problematic. And by the way, I don't know who has ever had a moment of anxiety who then sleeps like a baby. Like, it's really challenging. These things are inextricably linked. When we think of the big three, chronic pain, anxiety or mood issues, and sleep, it's hard to have all three in perfect balance if there's a little something in one of these realms, right? Mm-hmm. And I always tell people we're not really switches. We don't turn things on and off. But what we'd like to do is dial down things like anxiety, dial down things like depressive symptoms, and dial up things like sleep coherence, right? And then people generally feel better. So that was an important finding, to know that, this is the reason they're looking to use cannabis. The perimenopausal folks actually were more symptomatic than the postmenopausal individuals. Not surprising. But that gave us a really great indication about where clinical trials should also be focused.
And surprisingly, more people are self-medicating with cannabis than we know. And they are less likely to bring this up in a doctor's visit if they are self-medicating. And don't you think that's something that, that we should generally raise awareness amongst physicians, just to ask, hey, by the way, what are you using for your menopausal symptoms?
Yes. I unabashedly, yes. Undeniably, yes. And a lot of our folks are actually using products that are designed to be non-intoxicating. They're just looking for something to help reduce anxiety. Our clinical trial work demonstrates so far, at least knock on wood, that individuals really do seem to get a benefit from using products that are high in CBD, that are not intoxicating, in terms of anxiety-related symptoms. Observational data say the same. Over the course of a year or multiple years, people report feeling better with regard to anxiety and mood symptoms. And again, if we can dial that down, people generally sleep better. When you sleep better, you feel better. Pain is also exacerbated by lack of sleep and anxiety. These things are, again, inextricably linked. So if your healthcare provider is going to judge you, or you feel concerned about it, that's a problem. So I try very hard to do as much as I can in the way of educating healthcare providers. Cannabis is not necessarily what you think. We should understand sort of the good, the bad, and the truth about cannabis and cannabinoids, because it isn't a one-size-fits-all approach, and it isn't for everyone, but it certainly appears to be a viable option for many.
Now let's talk about the fun part, because there's also, I mean, you know, we were going to go here. So we're going to talk about the fun. Sure. Cannabis and sex.
Oh, yes.
Sexual
cannabis
desire. All right, give us the skinny. What's the story about cannabis and desire?
So first of all, when it comes to sex, remember, sex starts in the brain, right? It all starts in the brain. Absolutely. And there's no bigger buzzkill to sex in my mind than anxiety or pain. Like, I don't know anybody who's like, oh yeah, I'm in terrible pain, let's get at it. No one says these things, right? And like, no one's saying that. Oh yes, this is a horrible dental appointment. Please, no one says this. And when you look again at survey data, which is how most of these things begin or have begun, I think there was a survey of about 800 folks, mostly women, who reported something along the lines of 70% reported improved sexual function and sexual satisfaction after using cannabis. Not surprising, right? Again, people are less anxious. So you turn down anxiety, turn up relaxation, heighten your sensory experiences, and you feel better. You have a better sexual experience. Greater orgasm intensity has been reported. Now, biologically, when it comes to sex, while some cannabinoids are terrific for women for certain types of, quote, symptoms, let's say libido or vaginal dryness. For other folks, let's say, we have a number of men who say, I get to a point and then I'm so relaxed I can't possibly perform. Well, that's an issue, right? So it's a little bit of, I won't use the term slippery slope, but you know what I'm saying here. So
I know what you're saying.
It really depends. It can indirectly enhance sexual function also, again, by, decreasing anxiety, and people who report having better sexual experiences using cannabis report both direct and indirect effects. So I think that's interesting. We do know that there's also some reports, cannabis can be a vasodilator. So you may have, again, increased lubrication. Lots of locally applied products, I guess that's the kindest and most diplomatic way of saying this, have been reported to increase sensitivity, to decrease discomfort and pain. I will tell you that we have heard from a bunch of folks in an endometriosis study that we're doing. This is a big deal. Sexual health is health. And when people don't feel the ability to engage the way that they might want to, or the ways in which they used to, because of menopause-related symptoms or endometriosis, adenomyosis, a myriad of gynecologically mediated issues, it's a big problem. And it's not something that we should ignore. And the biggest message, or the most important message I try to give people, is if it's concerning to you, it should be concerning to your healthcare providers. We should find ways to help improve the status. We shouldn't just accept it. And if it isn't going to hurt and could significantly help, why wouldn't we try?
Exactly.
When it comes to sex, again, we know that good, quote, sexual health leads to good health in general. People feel better because they are better.
I agree, because doctors aren't, doctors don't like to have conversations that, you bring your whole self to that interaction. And so if you've got hangups and you feel uncomfortable about talking about it, you're certainly not going to bring it up with your patients. But I want to sort of frame where these sort of local cannabinoid or cannabis type products, because you can get them as oils, you can get them as suppositories, and where we would sort of position these would be, we know that the best thing for maintaining vaginal health, obviously, is topical estrogen, sure, in some form or the other, but that's your long-term maintenance. And a lot of women in menopause will still have to use, even if they're using systemic hormones or local hormones, they may need a little bit of something extra.
Right.
And these are the products like the, sort of local products you use as you would use a lubricant.
Sure. Locally applied, right, we like to say. That's right. Yes. For women, it's a vaginal suppository, sometimes rectal, yes, depending on what's, quote, what ails you, right? So sometimes people use these things rectally for different types of pain, like PID, pelvic inflammatory pain. People might use it rectally. Men often use them too. But for women, what you find is that people who are applying some of these products locally that is, sort of a vulvar moisturizer. And you see these things now proliferating in the marketplace. Some are celebrity based, some are not. Some boast this kind of vehicle, some boast that kind of vehicle. I would also tell you to be mindful. We have to be careful of what we're using and where, because again, that's different from putting it on your hands or on your neck, right? This is a little bit different. So you want to be absolutely clear about what you're using and where you've gotten it and what's in it. Because some of these things, when you disrupt the vaginal microbiome, we also don't necessarily expect that every single thing will be terrific and wonderful and roses down there, right? We don't want that. We have to be careful of that. That said, I think there are a lot of people who find great benefit in using some of these oils that are locally applied. And again, if there isn't anything to be concerned about, why wouldn't you try it? Some people only use it during times, immediately before sexual activity or just before they begin their period or the beginning part or at certain phases when they would normally be cycling if they're sort of, cruising through menopause, if you will. That's what somebody said to me yesterday, cruising through menopause. I thought that was great. Or motoring through menopause, I should say this person's really doing. But, there are certainly reasons to think about exploring these types of products.
This February, I've been thinking a lot about how we show ourselves and the people we love a little extra care. For me, that starts at home, and Cozy Earth makes it effortless. Their bamboo pajama set is lightweight, soft, and keeps you perfectly comfortable all night, so slipping into bed becomes something you actually look forward to. And their classic cuddle blanket, rich, plush, and irresistibly cozy, it's like a warm hug you never want to let go of. Cozy Earth is all about elevating the everyday with better materials, thoughtful design, and long-lasting quality. Whether it's for self-care or a Valentine's gift, their products turn simple moments at home into little escapes of comfort and calm. And the best part? You can try anything risk-free with a 100-night sleep trial and a 10-year warranty. Honestly, once you feel this kind of comfort, it's hard to go back. Share a little extra love this February and wrap yourself or someone you care about in comfort that truly feels special. Head to CozyEarth.com and use my code SECONDOPINION for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here. Celebrate everyday love with comfort that makes the little moments count. We're up to now, what is it, like 36 states in the District of Columbia that it's a lot.
It's a lot of states, but again, state and federal law are at odds here currently. Currently, cannabis remains a Schedule I substance.
Well, I just love the idea that when we're talking about perimenopause and menopause, there are a lot of different entry points, for how women can relieve some of the symptoms that they're having. And, I think that the more options that we have, the better it is for everyone. And, we've got to lose some of this stigma, not just about perimenopause and menopause, but the options that women choose as well.
And I will tell you this one thing that people may not know that's super important. Cannabis was re-legalized in this country in 1996 in California, right? For medical purposes. Despite that fact, we have zero data, longitudinal data on people using cannabis for medical purposes. None until our program. And I don't say this to toot my own horn. That shouldn't be the case, is my point. We should know the differences in terms of long-term effects of cannabis use from our recreational or adult folks, which I spent decades looking at, versus medical patients who use for different reasons, pursue different products, and of course have different effects. Our longitudinal data suggests that people really look pretty good over time, depending on what they're using and for what, relative to their own baseline. And so when we think about removing stigma, as you just said, for individuals, not just in perimenopause or menopause, but for all individuals, right? We are, first and foremost, we are uniquely human. Before we're, perimenopause or postmenopausal, we're humans. And everybody has or should have the opportunity to explore things that, again, if the potential benefit is significantly greater than than the risk. And it's something that everybody has to determine for themselves, given their own history and the products and all these other things. It's not for everybody. And we have very different thoughts about adolescents and emerging adults than we do for older adults. When the endocannabinoid system is aging, maybe a little tweak looks a lot more beneficial, which is exactly what we're seeing. But when we think about removing stigma from women, we should just be removing stigma in general, just for everybody. We see, reduced use of things like over-the-counter analgesics. That's important. Reduced use of things like opioids. That's important. And people report feeling better. So, I think that's pretty critical.
I want to get to our rapid fire right quick because there are a couple of things that I want to make sure that we get to. Okay. Whole flower versus vape. If you're going to do an inhalation product.
This is going to be like quantum physics. It depends. The answer is it depends on what we're looking for. Many will tell you inhaled products, no bueno, no good, no way. But our OG school folks love flower products versus vaped cartridges or oils. Vaping flower or vaping oil, also very, very different. Vaping flower avoids combustion. Vaping oil may introduce some other things. So you got to be careful of what you're vaping.
How can you vape flower? How does that work?
How do you vape flower?
Yeah.
You use a vaporizer. There's a little tiny oven and you pack it and the fancier ones have different temperature settings and you can absolutely vape flower. So yeah, you're basically vaporizing it, not combusting it. That's for the listeners who are like, what's the difference? Routes of inhalation, fastest way of getting an effect, moments to minutes, right? Anything that you inhale into the lungs, into the bloodstream, to the brain. So people often enjoy that particular route of administration, but flower versus oil, or flower, smoking flower, vaping flower versus vaping oil.
Okay. So ideally, that sweet spot in the middle would be vaping flower.
It's safe to say that whole flower products give you the range of cannabinoids in that flower. You hope that it wasn't treated with anything. There's always that negative side of me going, yeah, but yes.
Right.
Yeah.
Staci, I came of age in the 70s. Who knows what was in whatever that stuff was we were smoking? I just remember young people, there was a reason why we had double-sided albums. Staci, you know what I mean.
Yes. Extended
women
play.
of a certain age will know what I mean by that.
That's exactly correct. That's right. Some people do love vaping oil because you can actually control certain things when you create oil, as long as the vehicle is correct and not something that we should be concerned about, like vitamin E acetate or anyway.
Gummies versus inhalation products.
Like apples and Subarus, so you may encounter both in your daily life, but they're totally different. So any product that you put into your mouth that you ultimately swallow becomes a consumable, like an edible, like a gummy. Gummies have to be digested by the gastrointestinal tract, and then you're going to have first pass through the liver. Fun fact, Delta-9 THC, the intoxicating compound of the plant in your product, is converted by your liver into something more intoxicating called 11-hydroxy. So we call it the gift that keeps on giving. So rise time or time to get an effect. Instead of inhalation, moments to minutes, now you're talking about anywhere from 45 minutes or an hour to up to 3 hours. And you're going to get what I call the extended dance mic effects, right? So it may be a while before you feel like you're coming down. For people who have overdone it, it's not so easy to undo it. Once it's in, it's in. You can always take more. You can never, ever take less.
And here's a pro tip. If you have a gummy and you don't feel anything for 45 minutes, don't take another one.
Wait. That's right. That's right. Pro tip. Do not keep eating them. That's right. That's right. Fun fact. Again, the gift that keeps on giving. And so you'll have people who say, I feel terrific at this party. I feel horrible at this party in 30 seconds, right? So you want to give yourself up to 2 hours. And if one dose is a half a gummy, maybe start with a quarter or less than that, right?
Right. Yeah. Right. Because you're experimenting. You're trying to figure out what works for you.
That's right.
And last thing I want to ask you is what is the biggest mistake that people make when they're experimenting with cannabis?
I think the biggest mistake that people make is the assumption that all products are created equally. So someone will say to me, well, I took a gummy yesterday and I was at this place and then I took a gummy today and I was at this place and they were totally different. Well, of course they're different. They're completely different. You have to know what's in these products. And the medium, that is the actual form that the product that you're using is in, makes a difference. Again, a gummy has to be digested. It's a sugar water matrix, different from, a brownie or something else. A beverage actually will act a little bit more quickly, but very, very different from, for example, the study products that we make. A sublingual oil. Remember, the area right under your tongue is incredibly rich for absorption. If you really want to have something into your bloodstream quickly that you can titrate a little bit more easily than an edible, but isn't a route of inhalation, consider a sublingual oil. Wait 2 minutes, then swallow. That's important to know. But the biggest mistake people make is that cannabis is cannabis. It is not one size fits all or even one size fits most. And you can always adjust what you take by adding, but you can never go back. That's the other big problem. I'm sure you've heard these stories, right? Women say, my husband eats 2 gummies every night, so I took 2. Well, it was Tuesday before I felt better, right? So avoid that if you can.
Well, Dr. Gruber, this conversation was exactly what I hoped it would be.
Anytime.
So I want to thank you so much.
Anytime.
Let me tell you, whoever sat us next to each other at that dinner, I want to say thank you.
We know exactly who that was. We do know who it was. We know who that was, and she's
who
terrific.
Shall remain nameless.
Okay. She's terrific. She's wonderful. But yeah, it was a game changer. That was really that was fantastic. So great to be with you.
As always, I want to leave you with a few takeaways, what I call doctor's orders. Number 1, cannabis has been used in medicine for thousands of years, but modern research was stalled for decades by racist policies, not science. And that legacy still shapes what we know and don't know today. Number 2, the endocannabinoid system is real and an important part of human biology, particularly for women. Its interaction with reproductive hormones may help explain why some women experience symptom relief. Number 3, cannabis may have an adjunct role for certain menopausal symptoms such as anxiety and sleep. And many women are currently self-medicating for their symptoms. Please, if you are, tell your doctor. For more information on this episode, check out our show notes. Join us each week as I break down medical topics and leave you with expert advice. Have a question you want to ask? Have feedback for the show? Submit your thoughts on my website, drsharonmalone.com/second opinion.